Thank you so much, David. And I just want to share with the audience how much I appreciate the invitation, how much I appreciate David's enthusiasm and pursuit of setting up a comprehensive program for heterotaxy syndrome. This is something that was certainly missing, and putting the patients in the center of all of this. Us cardiologists, pulmonologists, immunologists, gastroenterologists, surgeons, and scientists, that's all super important. Having the patients in the center is even more important. With that in mind, what I would like to dedicate this talk to the memory of my teachers, Richard and Stella Van Praag. Stella was the person who introduced me to heterotaxy. Those of you who didn't know Stella or haven't heard about Stella, she was a pediatric cardiologist who grew up in Crete during World War II, which was quite influential in terms of her life. She was just the most wonderful person, and amongst many other things, she was fluent in classical ancient Greek and was able to read original texts. So some of the definitions here translated from Greek is thanks to Stella. There's just not enough time for me to tell you how influential Stella was in my life. And Richard is just a giant in the field of cardiac pathology, morphology. The two of them, a husband and wife, were just giants in our field. Richard just died at the age of 95 several weeks ago. So, my topic is heterotaxy nomenclature, and where we were, where we are, and where we are going. And what I'd like to do in this talk is to just spend a moment on why nomenclature matters, what's heterotaxy syndrome, which I promise, I know that this audience is familiar with that. How did we get here, current state, and where we need to go, or what I think we should go. So the cartoon on the right essentially suggests why do we need to spell out things that are seemingly obvious. Nomenclature is a system of names or terms or the rules of forming these terms in a particular field of art or sciences. It's a theoretical field of studying nomenclature, is something referred to as onymology or taxonomy. And the reason or reasons that we need nomenclature is that it provides a common, precise, and standardized language for communication. Without it, it's the Tower of Babylon. We would not be able to communicate effectively with one another, and we won't be able to analyze data in a meaningful way. We won't be able to compare and draw conclusions in any meaningful way. That's why nomenclature. As I promised, I won't spend too much time on what is heterotaxy, other than to remind everybody that it's defined as incomplete or inappropriate lateralization of the thoracic and abdominal organs. I'm actually quite curious as the field evolves whether or not there are some issues with the brain and other organs that we don't pay that are not currently we don't pay too much attention to. the origin is from Greece. Hetero is other or different, and taxis is order or arrangement. So a different arrangement. It refers to the visceral organs. And the etiology, as we understand it today, is a developmental abnormality of the normal process of left-right asymmetry. It's tightly genetically controlled. It's an embryonic process that begins approximately at age 3, so 19 to 21 days after fertilization. Oftentimes, the mother doesn't necessarily know she's pregnant at that stage, but the left-right lateralization process starts in earnest at that point in time. And it impacts multi-systems involved with a highly variable anatomic and functional manifestations. The left-right patterning that is extensively studied by biologists, geneticists, now for quite a while is a highly complex process. It's a foundational process during embryogenesis. And if you look at nature, you look at the most fundamental building blocks of structure in nature, from molecules all the way to the entire organism level. The concept of asymmetry is vital to life. And any abnormality in that process of asymmetry has major consequences in terms of phenotype and functional consequences. So this is on the left, right here. I don't know if you can see an arrow. You can. So this diagram just shows the process here from very early on, the primitive streak that develops on the dorsal aspect of the, there you go, of the embryo, is the location where the process of lateralization begins. And then you can see on the second phase here, the notochord developing, head fold, and then by 20, this is fish. By the time that you get to 24 hours in this fast-forwarding or fast-paced development, you can see the embryo with the head and the heart starting to loop. Let's see if I can make this. And this is just an illustration of the cilia in the primitive streak, causing the or moving around in a highly coordinated fashion that leads to a motion from right to left in order to initiate the process of lateralization. So we talked about the definition of heterotaxy, which is an impairment of that left-right lateralization process. And the diagnosis is established by a set of criteria as opposed to any single pathognomonic test. And that just has to do with the fact that we still have a challenge in terms of how to conclusively diagnose heterotaxy syndrome. This is this table summarizes the diagnostic criteria that we developed. This is back in a paper published in 2014, collaboration between geneticists, epidemiologists, and one cardiologist. And it was fun to negotiate that set of criteria. And what we came up with at the time were 8 categories. At the top, situs inversus totalis. Then that in itself would be would establish a diagnosis. And then in groups 1 through 8, having at least 3 features or more from a set of specific congenital heart disease, biliary atresia, situs abnormalities of the abdominal organs, spleen anomalies, isomerism of the bronchi, isomerism of the lungs, atrial appendage isomerism, and systemic venous anomalies. Looking back is fascinating. Turns out that you can go back to 330 BC, and and that's Stella's insights. Aristotle noted abdominal situs inversus in animals, and you can find that in his writings. And go and fast forward to the mid-1700s, a paper on partial situs inversus by Trochel, and then a series of either case reports or small case series that noted different aspects of heterotaxy syndrome. The paper from Ivermark in 1955 is very interesting and pertinent, because he linked the embryogenesis of the spleen with congenital heart disease and was the first to note the link between splenic anomalies and a particular pattern of congenital heart disease. So polysplenia and asplenia and normal spleen. And Stella, many years later, noted that single right-sided spleen very much goes along with the congenital heart disease that you see in asplenia. The term isomerism was first mentioned in 1958 by Grant and Labo, who referred to it when it came to the lungs. Van Meerop and Wigglesworth they are from the University of Florida, used it for the first time in the context of the heart and referred to right atrial isomerism. Richard and Stella in 1990 claimed or provided arguments why this concept is erroneous, and I'll touch on that in just a few slides. In terms of classification, the 2 most commonly used classification themes are either based on the status of the spleen, normal polysplenia, asplenia, or a single right-sided spleen, or isomerism that has been used to describe the lungs and bronchi, but also the right and left atria and the appendages. So these 2 classification schemes are most prevalent in today's literature. And certainly they overlap. Those who use polysplenia, asplenia, or single right-sided spleen can connect those to either left or right isomerism in one form or another. The truth is that there is a substantial amount of overlap between these 2 nomenclature schemes. And it is also true that neither one of those is actually adequate. Both systems rely on a pattern of cardiac and non-cardiac anomalies with only modest consistency. Isomerism exists in the lungs and bronchi, but in fact does not exist anywhere else. There's no isomerism of the liver, stomach, and spleen, and of course what's controversial is whether or not it exists in the heart. And there is modest at best relations between one of either nomenclature scheme and genetics and clinical outcomes. So, few words about isomerism. This is Richard and Stella's title in the paper published in the American Journal of Cardiology, saying that the atrial isomerism is an erroneous concept. They noted that isomerism came from Greek. Isos means equal, and meros, part, so equal parts. And they reminded us that the heart begins as a caudalocephalad organized straight tube that subsequently undergoes lateralization, and the heart doesn't start as a paired organ. And there are no cardiac, there's no cardiac segments that comprise equal parts. There are no two left-right atria, no two left ventricles, no two right ventricles, no two pulmonary aortic valves, and I think that you can get their argument here. And the atrial appendages, they can be similar to each other, but they are rarely identical. And in fact, the atrial appendages in heterotaxy syndrome is typically asymmetrically abnormal. In other words, they're both abnormal, but they're not classical left, they're not classical right. An interesting paper that was published by Louise Calder from New Zealand back in 2011. She's a pediatric pathologist, and she conducted a study of 306 specimens, heart and visceral organs specimens. And of those, 250 were with cytosolitus and 56 heterotaxy. What she found was that in patients with heterotaxy syndrome, bronchial atrial discordance occurred in 16% of the cases. In other words, in 16% of the cases, you could have, let's say, for example, bilateral left bronchi morphology, or left isomerism of the bronchi, but the atrial anatomy would not be that of bilateral left atrial appendage morphology. And she concluded that, and that's a quote, "No feature is completely reliable by which to diagnose thoracic situs. Bronchial situs does not always correlate with atrial situs and vice versa." A more recent paper published in 2018, Circulation Cardiovascular Imaging, from my good friends at SickKids in Toronto, looked at 110 patients at cross-sectional imaging, CT and MRI, of 110 patients with heterotaxy syndrome, defined as splenic anomalies. And they identified about nearly 40% with asplenia, nearly 57% with polysplenia, and 4% with normal spleen. The take-home message from this paper is that 20% of patients exhibited an incongruent pattern using appendage isomerism and spleen. So the appendage and spleen status could not be determined in 15% and 3.5% respectively, which one way to look at it is that notion of either categorizing heterotaxy patient based on the status of the spleen or the concept of HL isomerism is highly variable and unreliable. And I put this CT image down here in the right corner of the slide to make the point that they gave this example as one of a classic left isomerism and polysplenia. That actually one of the cases that in their view corresponded, there was alignment between the status of the spleen and the concept of isomerism. And I would argue that if you look carefully at these two appendages, they are not isomeric. They just don't, they both look abnormal, perhaps a variant of a left HL appendage, but they're not mirror image of each other. So together with Steve Sanders, we wrote an editorial to this paper, and also this is my summary slide. And what we pointed out is that the existing classification system used in heterotaxy are only modestly predictive of expected anatomic pattern and are inadequate to guide diagnosis, therapy, or to determine prognosis. And we called for to develop a new paradigm for classification of heterotaxy syndrome based on genetics, developmental biology, sophisticated imaging biomarkers, and advanced statistical methods to distinguish between different risk groups. So my own perspective is that classification of heterotaxy should be informed by all of these analytical methods in order to risk stratify patients that can then inform management strategies. And the development of such new paradigm requires a robust prospective national and international registry. We need data, and I understand that work is being done in that direction, and I'm here to help in any way that I can or Boston Children's can in order to make this as robust as possible. Thank you.